But again, this is not a treatment course that we would have gone down without having the information of the MRI and spinal tap. We would have said, hey, it's a tumor. Let's put him on some steroid. He would have gotten worse. That fits the course of a tumor, and he would have been euthanized. So instead, we got to the root of the problem and got that addressed, and he's doing better.
Welcome to Diagnostic Tails, Animal Imaging's Uncovered podcast.
Each episode offers insights into the world of veterinary imaging, sharing stories, breakthroughs, and advancements in imaging techniques.
Hey everyone, welcome back to another episode of Animal Imaging's podcast, our Diagnostic Tails podcast. I am Dr. Amy Armentrout. I'm the lead veterinarian here at Animal Imaging, and I'm lucky to be a part of this podcast about things that I get to learn about every single day because I'm mostly a horse veterinarian and we're pretty much always talking small animals. I'm joined by my co-host, Lon Hays.
Hello, hello. Thank you for having me back.
Yeah, he's our master small animal veterinarian here, spent time in general practice, and now he's an imaging king, right?
I mean, I work here, but that's kind of sketchy day to day. Yeah.
Yeah. And then excitingly, we're joined by Dr. Jennifer Rich today. So Dr. Rich, you want to introduce yourself a little bit?
Yes, I am Jennifer Rich. I am a boarded veterinary neurologist. I've been practicing here in the Dallas Metroplex for the past 10 years. Actually, I think it might be 11 or 12 years at this point. But I've spent the majority of my career in specialty practice and just recently have branched out into a realm kind of more closely resembling concierge medicine. So that's a really exciting development that is starting this summer, accepting clients now. So I'll have a lot of really exciting cases to show coming up.
Yeah, and we're super excited to have you. We get to work with you, little bits previously and a little bit more now, which is great because a lot of our small animal imaging needs a neurologist. And they're hard to come by in this area, so we're extremely lucky to have you.
Yeah, absolutely. And Amy, I feel like I learned something new about horses every time I come in too, because that was vet school many years ago. So that's always fun to hear that side of things.
Yeah. And you guys, I'm like a nod along. Yeah, that sounds right. I vaguely remember that.
Looks good.
Yeah. What do we want to kick off with today?
Well, let's talk about, for you, Dr. Rich, and for the imaging requests that we get a lot of times, we wind up talking about adding, especially for our neuro cases, doing a CSF tap. Most of our referrals from our GPs don't ask for that. And for a lot of neuro cases, it's a nice additional point of information to kind of round the case out. Can you talk about a little bit about what it leads to or lends to your cases if to get that information to go with the imaging and things we may not see on an MRI that can be diagnosed or brought to light with a CSF tap?
Yeah. Spinal tap is huge. I think of the MRI and the spinal fluid giving us two very different pieces of the puzzle. So the MRI is letting us actually go into the nervous system and visualize it. So look at the brain, look at the spinal cord, look at the fluid around it, look at the muscles. So it gives me that big overall picture of how things are going in the nervous system, but it doesn't tell me on a cellular level what's going on. So I could have an imaging, let's say that we have a 5-year-old mixed breed dog come in, it's having some brain signs. We do an MRI of its brain and everything looks normal. Well, first of all, that's great because it's ruled out a lot of things to be concerned about. It's ruling out a tumor, it's ruling out a stroke, it's ruling out a congenital malformation. But again, I'm missing that microscopic information. Mm-hmm. So spinal fluid is letting me look down at the cellular level of that fluid that's bathing the nervous system. So I can tell, is there inflammation present? So specifically for meningitis, encephalitis, it's a very serious disease, a very critical disease. And if we miss that on the diagnostic workup, then we think the patient is normal. And instead it has this very severe progressive neurologic disease going on. So. Okay. Spinal fluid just gives us that full picture from that cellular level, what's happening in that brain tissue, or spinal tissue for that matter.
Yeah, no, we like it as part, and definitely highly recommend it on the cases where we feel like it's indicated and safe to perform.
Mm-hmm. That's a key too, because there are times where people or pet owners in particular will ask me, why do I have to do the MRI? You think it's meningitis, can we just do a spinal tap? And even though we could, we're still missing that bigger picture. So the MRI tells us that other side. How severe is this disease? How much brain tissue is affected? And to your point, it might not be safe for that pet to have a spinal tap performed. They might have increased intracranial pressure where we could actually cause harm in that effort of trying to do them good and get a diagnosis.
Yeah.
And I think it's worth noting that we do them all the time here, right? They're
every day.
really safe,
Right.
especially with the imaging obtained ahead of time.
Right.
And they're so simple, even I can do them.
No, you're an expert. Yeah, it's one of those that, on our referrals, we especially from our GPs, we don't get many that request that, and I think that they don't realize how important it is, and also how. We're not adding a lot to our imaging time. We do it after the MRI, but we're going to we do an fluoro, so it's live where you can see where we're at, and it adds so much to the case, I think.
Yeah, absolutely. Even in cases where you suspect it's a disc, just go ahead and mark on there, hey, spinal tap if needed, because you guys are able to review those images and see, is this something that would actually be helpful for this case or not?
Yeah, and that's what we tell the clients when they're checking in the morning is typically, for us, the spinal tap, if we're doing that, is kind of a game time decision. If we see obviously a big disc or tumor, we may not need to tap. We've got an answer. So, and then we also tell folks that if we do tap, it doesn't mean there's not something on the MRI. It may just not be something obvious that we can see as we're going through, and we don't want to be under anesthesia for 5 hours reviewing images or having the radiologist look at something. So we're going to do that. So, but yeah, it's a big part, and I think some folks kind of overlook that as part of that neuro diagnostic workup.
Yeah. And if it is a case who goes to MRI first, let's say they don't have a spinal tap for whatever reason, and then they go see a neurologist, or the case is getting worse and we don't have an answer for them, then we're going back later on and doing that spinal tap, which means another anesthetic event for them when we could have gotten all that information up front.
And I think that's kind of the key. They're already under anesthesia. It's adding less than 10 minutes total anesthesia time after they've already been under anesthesia for, an hour and a half. So that 10 minutes is negligible, and it's just incredibly safe.
Yeah, exactly. No, I think it's a win-win doing those for sure. And I don't know what your experience, well, you're much better than we are.
Like a literal expert, you mean?
Yeah, the person has all the initials behind her name. We don't have those. But
it's just the alphabet.
How many, because we do have some that we wind up, we don't get fluid. Mm-hmm. So, I think we probably are maybe 10, 15% that we tap, and they're just dry holes. Mm-hmm. So I don't know if that's what you experience. Now we're doing low traps, not high taps like you do. We're not the experts. We don't do those. Yeah. Amy will, because she has a lot of alphabet letters too. I don't, so I don't do those. But what your experience is on kind of the dry holes.
Yeah, I get those too, and I primarily do cisternal taps. I will say I am not very successful at lumbar taps, so I bow to you for that.
No.
But those cisternal taps, even with those, sometimes I don't get fluid. Maybe it's just the patient anatomy or whatever reason, and that's frustrating because it would be helpful to have that information. But then you just have to kind of go back to your patient, look back at your patient, look back at their history. How long has this been going on? Has it been getting better or worse over time? And kind of piece that information together if you don't have the spinal fluid itself.
Yeah. Okay, cool.
All right. Do you have any interesting cases that you've had recently that you want to share with us, or that you can share with us?
I do. Last time that we talked, I was saying that otogenic meningitis is my favorite. It still is, and that's the case I'm going to talk about. This was a 7-year-old male neutered Labrador, and I kind of gave away what his diagnosis is. But he came into the primary care vet for vestibular signs. So just not acting right, some episodes of disorientation that kind of waxed and waned. So not your classic presentation of, hey, they're abruptly affected and gradually get better. This guy was kind of waffling, getting better, getting worse. This was actually a case that I did a virtual consultation with that veterinarian. So this is someone who wasn't able to come see me directly, but trusted their primary care vet, and that vet was left having to manage this complex case. So it was really great to be able to jump on the phone and just help guide them through that process. They actually did have MRI in the area, so they were able to do a full workup. So even with doing a consultation over the phone, we can still have that full picture of what's going on with that patient. So this guy was getting better, was getting worse, ultimately wasn't getting better on his own, so they went for MR. Kind of differentials that we would think about would be a tumor This was a middle-aged dog, mixed breed, not kind of a pure breed that you have certain diseases that pop to mind. So waxing waning course in a mature dog makes me think of a cancerous tumor. And this could be a very poor prognosis ultimately for that dog. So could have put him on some steroid, could have given him some time, let that steroid do its job, decrease swelling, inflammation, without really knowing what was going on. But instead we did the MRI, and it's so good that we did, because we found the actual problem. It was a disease that would have gotten worse if we had put this dog on steroid. A lot of neurologic conditions, we use steroid and they get better, whether it's an inflammatory problem or a cancerous problem or an autoimmune problem, a disc rupture, a lot of them do better on steroids. But this particular dog would have gotten significantly worse because he had infection in his middle ear that had crossed over into his brain. And I mentioned last time that the cats are a species that's very commonly affected by this, or the French bulldog that we just love talking about, or any of those little flat-faced dogs. But this was more a dolichocephalic, so more kind of a Labrador mix. So not something that we were kind of expecting. Didn't have any external ear infection, so nothing external that would have led us down this track. So the MRI was invaluable in telling us what the precise problem was. Speaking of spinal taps, they were able to get a spinal tap on this guy. And for reference, white blood cells in the CSF should be negligible, like 0 to 5 cells per field. And this particular dog had 5,000 white cells.
Wow.
And mildly elevated.
Just a smidge.
And for reference, again, like a autoimmune type of meningitis, we're talking hundreds, but 5,000 white cells. So definitely there was inflammation from that middle ear infection that had crossed over into the brain. No obvious bacteria. It looked like it was just kind of irritation. Before I had a chance to consult with the veterinarian, they had gone ahead and started some antibiotics, and the dog had gotten 95% better. So thank goodness, because I looked at this image, there was significant swelling in that brain, significant inflammation. Like, this is a dog that I thought was not going to survive to the time that I had the consultation 2 days later. So the vet was good enough to recognize the problem, start the antibiotics. The dog responded really well to that treatment. Currently still doing well, but I do think ultimately this is going to be a case that we'll probably talk about going to surgery to really clear that infection up. Right. But again, this is not a treatment course that we would have gone down without having the information of the MRI and spinal tap. We would have said, hey, it's a tumor. Let's put him on some steroid. He would have gotten worse. That fits the course of a tumor, and he would have been euthanized. So instead, we got to the root of the problem and got that addressed, and he's doing better.
What antibiotic did they start him on?
They actually did a combination of clindamycin and Baytril.
Okay.
I typically would do like a combination of Clavamox and Baytril, but this dog, again, had gotten 95% better. The problem with infection in the brain tissue is that we don't have great antibiotics that cross the blood-brain barrier.
Right. Yeah.
So it can be very much a challenge. And kind of the same thing with the middle ear. It's hard for antibiotics to really penetrate deep enough to do some good. And when we talk middle ear infections, it's goo. Think of like an abscess that's walled off, that antibiotic isn't going to get in there. So that's often the case with these dogs with the middle ear infections too, is that often surgery is the way that we really go in and clean all that material up.
I think there's an important point there too, because I think, me being a horse person, right? I think it's easy to say like, oh, I think this dog has a brain problem. And I would just say, oh, I guess, what's an MRI going to show us? These things aren't treatable, like just be done. But now that, on this side of it, when I get to see what you guys do with the small animals, like there's so many things that are treatable that you can do something about. And so like now I've kind of switched from what I am, MRI my own dog's brain. Like now I would, whereas before I probably wouldn't have.
Yeah, there are so many things that we can treat, even with dogs and cats who look very severely affected. There's still things that we can do in a lot of those situations. I had a very similar experience working with an emergency veterinarian. We had started up a specialty practice that had originally been an emergency center. So they were used to seeing those patients come in. Hey, they were fine. Now they're very severely affected. Well, it's something bad. It's neurologic. We'll just euthanize. So it was really great to start working with that ER vet and have her see us work up some even brain tumor cases. We would have brain tumor dogs come in that were actively herniating their brain, like very late stage disease. Got them worked up, got their diagnosis, got them on the proper treatment to decrease brain swelling, and got that dog back and got their personality back for months. So it was good for kind of me to see their perspective of things, and also for them to see, hey, there actually is more that we can do for these patients.
It was really eye-opening for me when I first started here, that like, hey, wow, you can do brain things in small animals.
Yeah.
You can in horses too. You better hope it's an infection.
What we talked a little bit in our first podcast about seizures. I was going to revisit that a little bit just for like our general practitioners like me. The dog that comes in, I want to kind of go through like young, middle age, old, like your progression of workup and what you recommend, and when do we wind up at an MRI for those, that young dog, the 2 years of age that has this onset of seizures, and you can walk through as much or as little as you want to. It's like we've got a solitary seizure, a cluster seizures, and your workup, and when do we wind up at animal imaging looking at a brain?
Yeah. The sweet spot is between 1 and 6 years of age.
Okay.
If that dog or cat is between 1 and 6 years of age and they're otherwise neurologically normal, they're not a little toy breed dog like a Maltese, Yorkie, Chihuahua, then it's most likely that it's idiopathic epilepsy. And if they just have a single seizure episode at the onset, which is part of the definition of idiopathic epilepsy, then those guys are mostly okay to just medically manage them, monitor them, see how things go over time. If those seizures are well controlled, if they stay neurologically normal, then we don't necessarily need to do an MRI. The conversation I have is it's always good to have one. Information is great. Make sure there's nothing that the dog was born with that might get worse over time. But ultimately, if those seizures are controlled, the dog is doing well, we can just treat empirically. Mm-hmm. Where I get concerned is those dogs that are less than a year of age and having their first seizure, or dogs over 6 years of age, or the ones that cluster the first time that they ever have an episode. Okay. So those are kind of your three kind of triggers to say there might be something more going on here. Additionally, those dogs who are neurologically normal after the seizure happens. So not in that recovery period, but once the seizure is done, they've recovered and now they're just compulsively walking in circles. Their vision is off, their personality is different. Right. Those guys, that's also a big trigger that there's something going on.
In your experience with those dogs, and back to kind of your normal, not normal, but the 1 to 6 idiopathic epilepsy, do you have a percentage that manage fairly well on anti-seizure medications, and how many that just maybe don't? Mm-hmm. Where that line falls?
It very closely resembles what we see on the human side. Okay. So about 33% of dogs do not respond to anticonvulsants, meaning that they still have a high frequency of seizures despite a medication being kind of at its maximal dosing. Okay. That means that 2/3 of dogs do respond well to treatment. So it's definitely worthwhile to get these guys on medication. But I always prepare owners that, hey, we might just start with one medicine, but we might be adding on more drugs as time goes on. We just have to give this disease time to kind of show itself to see what type of tight regulation your pet may or may not need.
Yeah. And for us, the ones that we see that are in that 1 to 6 that are having kind of breakout seizures or not responding, they're usually on multiple phenobarb, Keppra, potassium bromine. They're on several meds. Yeah.
Yep. And those are the ones that, they started out as a presumed idiopathic epileptic, but their seizures are getting worse despite our anticonvulsant therapy. Those are the ones that we would image, even though they're in that age group. We're still suspecting it's idiopathic because we want to make sure, hey, our medicines aren't working. Are we missing something that we need to be treating in addition to the seizures? Because seizures are a symptom of an underlying disease process, whether that be epilepsy or brain tumor, stroke, inflammation. Mm-hmm. It's a symptom of that underlying disease. So if our symptoms are getting worse and our treatment's not working, it's time to investigate more and just make sure that we don't need to add on a different class of medication in addition to those anticonvulsants.
And are these still dogs that you'll do a CSF tap on, if any?
Oh, yeah, absolutely. Even if the dog is completely normal at home, but they have some sort of neurologic symptom, even if it's episodic, then having that spinal fluid is still warranted, especially in the face of a normal MRI, because we're missing that piece of information if we don't look.
Kind of ties it all together.
Yeah, give as much information as you can at one time to help things.
And if you think about the disease processes, if you have a normal MRI, that could either be, a normal patient, which means no treatment is necessary or symptomatic treatment is necessary, but it's not going to get worse over time in the way of having new signs develop. It's just going to be seizures. It's not going to be seizures plus blindness plus weakness. Yeah. So a normal brain is a very comforting thing. We've ruled out a lot of things to be concerned about. But if we don't have that spinal fluid and we can't confirm 100% that it's not meningitis, we could be missing a very serious disease that will get worse, will become even life-threatening to that patient if we don't initiate treatment. And they respond much better if we initiate that treatment early on.
Yeah.
So if we miss our opportunity to get that diagnosis, that can be very detrimental for that patient when we could have intervened sooner, gotten them on aggressive immunosuppressant type of therapy.
Yeah.
Good to know.
That's great information.
Yep.
So let's say I'm a referring veterinarian in this area and I'm just lost on my seizure workup, or I'm overwhelmed with, I'm a newer grad or whatever. So, but you're available to help veterinarians walk through these cases, because, I think there's quite a long wait list to get into a neurologist.
Mm-hmm.
There's a few different practices in Dallas now that have neurology, but it's still such a high need specialty that there's always going to be a wait list. And there are some cases that they can come in through emergency, get stabilized before seeing the neurologist, but ultimately it's going to take you some time to get seen. And there's still that population of pet owners that don't go for referral, that can't, or physically can't, financially, whatever, and they're still left with their patient who's neurologic and needs help. So where I kind of step in is by offering two different services, no matter what that patient or what that family is looking for. The specialty traditional hospital setting is the place for people who need to be hospitalized, need to have their pets hospitalized, who are very sick, who need surgery. But there are other avenues that people can get a workup done these days. So for those pet owners that want to stay with their family vet, they have a very close relationship with them and they trust them, then virtual consultation is very helpful for them. And like you're mentioning, that newer grad who this is just their first time experiencing this, they don't have a lot of years behind them to know what kind of works or doesn't work. They can reach out to me by phone call. I review all of the medical records, and we have that kind of deep dive discussion on what could be causing this, the differentials, what tests can be done in that home clinic setting, because MRI, of course, gives us the most information. But if that's not an option for us, then we still have a lot of different types of blood work that we can do to make sure the pet is systemically okay and to make sure that they're going to tolerate the medicine that we put them on. So we talk through all of that, make sure everything is safe for the patient, and then talk about treatments and ongoing care. Then on the other spectrum, there are those pet owners who want a very close and personalized experience. Their pet is their child, which I think that goes for anybody these days. Our pet are our children, and they want to have more time to sit down and really talk about not just the diagnosis, but what does this mean? What does this mean for me and my kind of lifestyle at home and caring for this pet? Not just giving me a diagnosis and a treatment plan, but really helping me understand that process and help me walk through that process. So that's where VIP Neurology comes in, where I meet with the pet owners here at Animal Imaging. We get that full workup done. We get to the root of the problem, and then we kind of move on with the treatments and having them come back for a recheck evaluation so that I can physically see how that pet is doing.
Yeah, and I think it's just so people know, like, you've got access to your patients on our system. So when they're getting scanned, it's really helpful for us because we've got a neurologist looking at them in real time and making decisions on, do we need to add scans or where are we going to go on these cases? So it's kind of nice on our end.
Yeah. And from a neurology standpoint, looking at the MRI, I think of that as very different from a radiologist looking at the MRI. Radiologists will have a beautiful full report of every single detail of that MR, where I am specifically looking at the brain or specifically looking at the spinal cord. I kind of have my focal goggles on, just looking at those areas and not so much looking at a radiographic description, but more, this is what the disease is, this is my patient, how do those piece together, does this image make sense with my patient so that we can have that treatment go forward. So it's a combined effort between the radiologist, the clinical pathologist when it comes to spinal fluid, the neurologist, but also that general practitioner back at home. Because a specialist is not a replacement for that general practitioner. I like to say I'm very smart in a very small subject matter, whereas primary care vets, they know everything about a lot of subjects. So you need them to have that overall care for the patient, so they can keep that big image picture of how the pet is.
Well, back to your services. So how do people contact you or use your services while we're on that?
On my website, it's updated as of yesterday, went live yesterday with the new services. So I had been doing the virtual consultations for a while now. The VIP offering is a brand new service. I'm able to practice here in the Dallas area again, so it's great to be back in the Metroplex. So you can go online to virtualvetneurology.com. That does cover the VIP service as well, but Virtual Vet Neurology has all the information for you about the different service offerings, but primarily for referring veterinarians, there's a case referral form. So you fill that out with all of the information, actually very similar to what they fill out for getting an MRI done too. So then I review that case information and determine from there, what is the better fit for this patient? Is this a patient who would be best benefited by a virtual consultation with a veterinarian? Or is this someone who is ready to do that full workup and ready to have that face-to-face time with a neurologist, and they would qualify for VIP? We would get them set up for the MRI and kind of take it from there.
Cool. And I don't know how all this tech stuff works, but maybe we can put a link to our podcast to find Dr. Rich. And if that doesn't work, just call us and we'll find her for you.
Yeah, I think we will always find you.
Yeah, we'll find her. Yeah.
We all have our areas that we know what we're doing. And when there are areas that we don't understand, then we reach out for other people.
Yeah. I reach out a lot. I spend a lot of time reaching because I don't know.
I have to call John to get help with my email. Like, let's be real.
Yeah.
Right. You've got a lameness problem or you need something surgerized on a horse. Like, I'm your girl. Right. You need your email checked. It is not me.
Yeah, we're not figuring that out. Yeah. I'm there with you. Another thing I wanted to talk about, and this is kind of from our general practitioner referrals on some of these neuro cases, and I don't know how to cover this exactly, so I'm going to ask you, but trying to localize lesions a little bit. So I think sometimes, and I was this way before I started working here and became a little more educated in MRI and CTs, but as we're checking areas of interest, sometimes in quite a few referrals, we get check every box from brain to lumbar to, and it's like, I can't image all those at once because anesthesia is what's going to take forever. We're going to have issues, but trying to help localize lesions a little bit as to where we may want to be looking for things. I don't know if you can kind of touch, we don't need to go down that rabbit hole 100%, but like touch on that a little bit about like what, you're seeing this, maybe image there. And what they can ask you or ask us to kind of help kind of narrow that down a little bit.
Yeah.
So wait, before you get started, I just want to interject. The reason you can't check every box is because we can't use electronics in the magnet. It's an electromagnet, so we can't have things that plug in there. So we can't have heat support, and the magnet's cold. So you put something in, and it's going to be a popsicle if you leave it in there too long. So
yeah, exactly. So they become hypothermic. Then we have blood pressure issues. So and each of those areas we're imaging, depending on the size of the patient and what we're looking at, can be anywhere from 35 to 45 minutes per
area. Correct.
Per site, exactly. So a cervical neck is a site. So we don't. It's not like TV where they go whoop, whoop, and we did.
Yeah, it's not just like this magical tube where the whole thing goes in the whole tube and we get everything.
I wish it worked that way. It doesn't.
So I just thought I'd interject that so people understand why we want to localize.
Good point. Exactly.
I think that comes from two different areas. One is that when we do something like a radiograph, I think we get very comfortable with just kind of doing that dogogram or doing that catagram. Like, I know this is wrong, but I just want a glimpse at the abdomen. Yeah. So it's very easy to do that with an x-ray. You take a shot and then you're done. You can see it on the screen, especially with DI now. The other part of it falls on neurolocalization and having that fear of how do I localize? Am I going to localize the right spot? All I know is this pet is neurologic and kind of putting our blinders on and our hands up. So if we kind of go back to our basics of what we learned in vet school on neurolocalizing, it will help quite a bit with that. And just like you guys are saying, the most important factor with that is the patient safety. So they're going to be under anesthesia for an extended period. And a lot of these dogs with neurologic issues are those little toy breed dogs. So the ones that can't regulate anything very well. Mm-hmm. And along that note, a lot of our patients are French bulldogs. So we don't want those guys anesthetized for very long for GI reasons, respiratory reasons, what have you. And it just gives us a better picture too. If we know the area that we're looking at, we don't want to image an area that's not relevant and then have to decide if we find something, do we need to do anything about it? Right. So for example, if we have a dog who has a neck problem, we image their entire spinal column, we find a chronic disc in their back, but they have no clinical signs of it, what is our obligation there? Do we need to address it or not? But really the most important thing is knowing, where is the problem coming from in my patient? Are they mentally appropriate? Do they have cranial nerve issues? Cranial nerves are something I touched on last time, where we as neurologists like to get into the nitty-gritty of it. We like to know all the different pathways and how they interconnect, but it's honestly not that important for general localization. If your pet has a cranial nerve issue, or if your patient has a cranial nerve issue, it's going to be coming from the hindbrain. Vision and smell excluded from that. Any other cranial nerve problem is going to be the hindbrain. And we have our kind of certain disease classes that affect the hindbrain more so than the forebrain. Think inflammatory type of diseases. Then if we have personality changes or seizures in particular, that's going to be the forebrain. And regardless, that's all the brain. So if you have any of those issues, if they're mentally inappropriate, we're imaging the brain. You don't have to worry so much about the spinal cord. But if that pet is neurologically normal from a mentation standpoint and cranial nerve standpoint, now we're talking spinal cord. And the spinal cord has 3 different sections. In a Great Pyrenees or in a Labrador, each one of those sections is quite long for the MRI. So we do need to know, is it cervical, thoracic, or lumbar? And that's where you default back to your spinal reflexes. Keep it basic. Withdrawal reflex for the front legs, patellar reflex and withdrawal reflex for the back legs. If those are intact, remember upper motor neuron means C1, C5, or T3, L3, kind of those bigger chunks of the spinal column. If you have reflex deficits, now you're talking intumescences. So C6T2 or L4S3, that's where those nerves are directly coming out and going to those legs. So if those are affected, you're not going to get that withdrawal reflex. Which brings me to a very important fact of withdrawal reflex versus nociception. So let's say you have a paralyzed dog come in. It's vital that we know the difference between, does this dog feel its paws versus not feel its paws? And that's vitally different from a withdrawal reflex. A reflex is only a communication between the paw and the spinal cord. There's no higher communication. That information is not traveling up the spinal cord to the brain. It's just a local communication. So if there's a reflex there, but you pinch even deeper and that pet does not respond to you, so they don't turn their head, they don't try to bite you, their respirations don't increase, their pupils don't dilate, then that means they do not feel it. That means that the information that should be traveling up to the brain is no longer doing so. And that tells you a big prognostic factor. Reflexes don't tell us about prognostication, but nociception does. So reflex, great, that means the nerves are working, but if they don't recognize that you're feeling on their paw, then that might mean that they're not going to get recovery, or that they will get recovery if they do have that feeling. So that's a big communication point to have with pet owners.
Yeah, those sections that I try not to think too hard about.
Yeah.
I'm not going to lie, I use a cheat sheet on horses. Even though I tell people I'm not dumb, there's a reason I didn't go into medicine, right? I went into surgery. So I get my cheat sheet out for my neuro, my equine neuro.
Yeah. Well, that definitely helps. I think our general practitioner and us, when you're trying to, like you said, we localize, so we're imaging correctly, and we're, at the end of the day, spending money correctly for our patients. We're not imaging things we don't need to image because it can add up fast.
Mm-hmm.
Yeah.
So anything new and exciting in neurology that we need to be aware of?
No.
There's some comfort in that, right? Like that you learn these basics in veterinary school that will serve you well in general practice. And then when they need extra, they've got you.
Mm-hmm. Yeah, the basics are always tried and true. I will say there is something that's kind of becoming more and more prevalent, or that we're becoming much more aware of. I think it's always been here. We just haven't been aware of it. We've been kind of misclassifying it. Is a condition called paroxysmal dyskinesia. Big fancy word. It's basically a movement disorder. These episodes resemble seizures. So oftentimes the way that the pet owner describes it will sound like a seizure, or we'll just hear, oh, they collapsed and they were convulsing. Okay, then it's a seizure. But we need to really stop and pause and ask more detailed questions about that event. A seizure, there's kind of 3 main questions that I ask about it: the before, the during, and the after. Before the seizure, before the episode, was there anything that seemed to set it off? Anything that triggered it to happen? Oftentimes with seizures, they happen out of sleep, or there's not any type of trigger that occurs, versus something like syncope. The dog was out exercising, running around, playing, and then had a hard time breathing and collapsed. The second part is the episode itself. what was the pet doing? Were they very rigid? A dog who's rigid will more often be a neurologic event versus flaccid is going to be more often syncope. Were they convulsing? Were they actually having kind of that shaking type movement? And were they having any autonomic signs? Did they urinate, defecate, or drool excessively? Autonomic signs are much more classic of a seizure than the non-seizure type of events. Okay. And then lastly, the recovery period. Did they just pop right up and they were okay? That's not a seizure. Or did they have that more gradual recovery where they just kind of gradually came to, they were a little bit disoriented, they had to lay around for several minutes to hours before they really got back to themselves. So taking a little bit of time and asking those more detailed questions can help us decipher which of these is going on, because a paroxysmal dyskinesia or movement disorder will present almost like the body is presenting like a seizure. There can be convulsions, there can be kind of uncontrolled motor movements. Often there's kind of flexing and extending in rhythmic ways. But the key with a movement disorder is that pet will maintain its consciousness. So they'll be able to react to their owner. They'll turn when their name is being called. They'll look at the owner. They oftentimes will have a very worried expression on their face too, because they're conscious and they know their body is moving in a way that they can't control.
Sounds worrying.
Mm-hmm. Yeah. And I have a really great video. I mean, you can look these up on YouTube, but a person having a certain type of paroxysmal dyskinesia, and I put that up against like a little border terrier, and they look identical. So it's very interesting kind of how human neurologic conditions look very similar to our pet neurologic conditions too. The main reason we need to differentiate those two types of episodes is that seizures, we put them on anticonvulsant medication. Those anticonvulsant medicines can have their own side effects, or they can affect the liver, they can affect the level of awareness. So we want them in the patients that need them, but we don't want to necessarily put them on our patients that don't. So movement disorders do not tend to respond to anti-seizure medication. So for those guys, we don't need to think about like phenobarbital and monitoring blood work. We don't need to worry about bromide. Some of them, interestingly, will respond to a gluten-free diet. So a diet change is always something that I offer for those patients. Otherwise, it's a lot of benign neglect and just kind of trying to find something that might set them off into having that episode. Some of them will be excitement induced. Others tend to just happen when they're going to happen. Right. But if you can find a trigger, try to minimize that for them.
Back to seizures and for your general practitioner, at what point, let's say for our owners, our parents out there, at what point with seizures do you seek help? It's the weekend and Fido has had 1, 2. At what point do you go, I need to get in somewhere? Mm-hmm. Where's your line?
Where do you hit the ER versus get an appointment with your regular vet?
Exactly. Mm-hmm. Yeah.
If this is their first time ever having a seizure, I would take them in right away, because we never know what set off that first seizure. Maybe it's just going to be an idiopathic thing, but there could be something underlying it. So definitely that first time seizure, just take them in, get them seen. Most seizures are only going to last about 1 to 2 minutes. So I typically say stay at home, let them kind of ride out that seizure. If it's lasting 5 minutes or longer, it's time to load them up and get going. But if it's a minute or two, they come out of it, they're a known seizure patient, I would have them stay at home. As long as that dog comes out of it okay, and they kind of get back to themselves, just stay at home. If they then go into a second seizure in that same day, or if that seizure is lasting for 5 minutes or longer, again, those are kind of your big cues of this may not self-resolve at home, and we might need to get some IV treatment to help.
Yeah, good to know. Good to know.
Yeah.
Is there anything you want to talk about?
Like, is there burning neurology things or life things, or
World Cup.
Oh, geez, no.
No. Wine tasting.
I do enjoy wine tasting. Yeah.
We should have had wine. I told you. I've been asking for a margarita machine here for 5 years.
Did you not see today on the list, on the inventory things about what we need to order? I put margarita machine on there.
I don't think Susan.
I also put slip and slide. So I don't know that I don't know that I'm going to get.
Susan said we get a shower curtain and some Dawn.
So correlating equine and slip and slide, when I was in my residency at Mississippi, we took these long like plastic tarps from equine, and like they had huge containers of lube. So
the J-Lube. Good
So we
old
put that
J-Lube.
across the tarp and then put water on it. And it was the best water slide that
there you
we've
go.
ever had.
Perfect.
Yeah.
Most fun you'll ever have, because J-Lube comes powdered, so you can mix it with water, and it's the slipperiest stuff I have ever touched in my entire life. And you can slip and slide for days with J-Lube. So
Nice.
I've actually got some at home. The kids may or may not have had a J-Lube slip and slide experience already.
Good to go.
Veterinarians are fun.
Yeah. Well, while we're here, I mean, I can't get him on camera. Let's talk about your friend.
My friend.
Yeah.
This is
the coolest stuff ever.
I know he is. This is pretty boy Floyd.
Oh,
His
that's
ears
good.
perked
Yeah.
up.
Yeah.
So
Yeah.
Floyd is he's my newest project. So
Yeah.
I'm a puppy raiser for Freedom Service Dogs. It's a service dog group based out of Denver, Colorado.
Cool.
They primarily raise dogs to be service animals for veterans or people with physical disabilities, mental disabilities, what have you. And for I guess I should say they breed their own dogs. They used to get them from the rescue like shelters, but found there were just a lot of behavioral issues in the dogs themselves they needed to work through. So now they breed their own dogs, and from the time that they're weaned until about 4 months of age, they go into a prison system. So the prisoners do their early raising, and then from 4 months to about 14 months of age is when people like me get to take them into their home and raise them during that time.
Okay.
So I do all of his basic training. I take him out to public places and get him used to different experiences. Like right now, he's not even a year of age, and he's just laying by my feet.
Yeah, he's just
very
hanging
quiet
out down
the
here
whole
at your feet.
time.
Yeah.
So he's been an angel. And it was kind of fun the other day. Again, we just do his basic training. So we do sit, down, heel, that kind of stuff. Nothing that's specific for their purpose. And the other day, my mom and I were walking him, and we're like, those videos are so cute when people like pretend to collapse and their dog,
It checks them.
helps them, or just like completely ignores
It walks off.
eats the steak off the table or something. So we decided to give it a try, and I fell down, and he immediately went to the food bag and just shoved his nose in there and ate all the food that was in it. So I was like,
Nice.
cool.
Way to go, Floyd.
I mean, so
But-
he's an energy conservationist that also recognizes opportunity,
Yeah.
right?
Exactly. Yes. So actually, he's very smart. But we decided to recreate it because we didn't get it on video. So I did it again. Apparently, my acting skills were better the second time, says my mother. But this time, he put his nose on the food bag again, but then immediately went up to my face on my neck and just started licking me. I was like, okay, well, he could just be playing. Like, that's part of his play behavior. So I tried to get up, and then he got this like really serious look on his face and just laid right on top of
Really?
me, like curled up,
Aw.
which he doesn't do. Like when we're playing, he'll like play on top of me, but he won't lay down. And yeah, it was just really incredible to see him do that, like naturally doing a pressure therapy, like deep pressure type of response. People who have seizures, when they have dogs that will do this for them, they'll lay on top of them until they become more conscious and safer to stand up. So I tried to stand up, and he wouldn't get off of me. So he just stayed right on top of me. And it was just such a lovely moment because it wasn't expected. We didn't train him to do that. It just kind of came naturally to him.
Right.
So we're really excited
Genetics.
to see what he's going to do once he goes into his formal training.
So for the so you have him from 4 months to 14. Then he goes back to Denver, and then they kind of fine tune what his special skill is going to be and where he's going to be placed.
Yeah, they call it.
How long does that take? In general, do you know, like at that point till they get placed?
I believe it's a year or two. It kind of
Okay,
depends
wow.
on the dog and like what they're being trained to do
Yeah.
or who the person ultimately is going to be. But they call it going to college, which makes a lot of sense because when they start, they don't exactly know what their purpose is going to be. But as they work with them more, they kind of find out what their strengths are and what kind of comes more naturally to them. So
Right.
the dog that we had before him was very much like a retriever type, like physical, like give me a job, give me something to do. Floyd is very much more the like, I love you. I'll give you attention. I'll lay on you. Like he's much more on that emotional side of things. So I think they'll have two very different jobs, but they're going to serve people beautifully.
Yeah, that's awesome.
Yeah.
And a good organization and good for you. That's awesome.
Yeah.
Yeah, love to see that. And I'm going to ask this question which I feel like is ridiculous because I already know the answer. You're shaking your head at me.
I don't got one.
At the end of
Amy,
every segment,
I don't got one. I said I don't got one.
The end of every segment, we have the tail end, which is supposed to be a tip or trick that you can use in practice. And it can be related to what we've talked about in the podcast or not. And this is what, like 10 times in a row you failed me. At this point, I don't even know if it's a segment for us, like, honestly. So I'll shift my focus to Dr. Rich. Do you have a tail end tip? It's a little nugget of take home information that a general practitioner could use either in practice and like it doesn't even have to relate to neurology or anything.
Oh, it has to relate to neurology. Neurology is just
I don't know what I was thinking there. I'm sorry.
I would just say, remember that as veterinarians, we're all a team. Just because someone has more letters after their name or has been practicing longer than you, we're all serving the same purpose for these pets and for their families, and we're all here to support each other too. There's a lot of terminology around burnout and around mental health and suicide awareness in the veterinary profession too. And I think we need to get back to remembering that we're all in the same profession and we're all doing the same thing, and we all can bring different pieces of information to a patient that we're working up in particular. So it's really good that we kind of have that conversation with each other. If you guys have a neurology patient that comes in and you just don't know what the heck to do with it, call me. That's what I'm here for. I'm here to help with that. When I was working in the traditional specialty hospital setting, it was great because we got to help a lot of patients and we got to do a lot of treatments for them, a lot of surgeries, a lot of kind of intensive care. But it also left us with not a lot of time to really sit down with those pet owners and really have that deeper conversation of, okay, I can do what I can in the hospital, but this pet is ultimately going to go home with you. And there's steps that you need to do to help them out too, and ways that you need to be supported in helping your pet. So that's where I'm really kind of hoping to step in with this new career path, is not following that traditional model, but looking more at the human medicine side as a guide, and looking at the concierge medicine that they're doing on that side, where we as practitioners can sit down and have more time with our primary care vets, keeping them in the loop with the care of these patients, have more time to sit down with those pet owners and really make them feel heard and understand what's going on with their pet, and having that direct communication with their neurologist and not having to go through a phone tree or have to wait months to be seen again. So just remember, we're all part of a team. We're all here to support each other. Let's get back to that and just get back to having a fun time in medicine.
Yep.
That's a great tail end tip.
Like it. I agree.
Where were you?
I was going to say exactly what she said. She kind of stole it from me. I'm going to be honest.
Yeah. Uh-huh. Putting out her candle doesn't make yours glow any brighter.
Are you sure?
Okay, well, thank you, Jennifer Rich, so much for being here with us. It's always fun, and we love having you. Somebody who's way smarter than we are, so really appreciate it.
Just in different ways.
Thank you for joining us.
Well, thank you for joining us for this episode of Diagnostic Tails. This is Animal Imaging's podcast. Maybe we'll have a link to Dr. Rich's neurology service, and if we don't, just reach out to us. We can get you in contact with her. Yeah, and then remember your neuro workups, right? And she makes them sound so simple.
Yep, 100%.
All right, thank you.
Thanks, guys.